There are some specific studies. I don't want to go over these in detail because we have limited time, but the data on reducing smoking in pregnancy is very strong. And a meta-analysis where they combine data from studies that have gone on in 4 different countries shows that if you can reduce smoking among pregnant women, even with a 4% cessation rate, you have major implications for the ultimate outcomes of low birth weight and the effect on the offspring of those pregnancies. A 4% cessation rate in the United States, if you extrapolated, would result in a $77 million saving in direct medical costs in the first year of life alone. And the cost-benefit ratio is 12-to-1 for these pregnancy cessation, smoking cessation programs. Similarly, we now have a series of programs that have been tried in different places and relatively good designs that we have confidence in that show that counseling smoking mothers can reduce the exposure of young children to secondhand smoke. We know, again, that tobacco taxes and the price of tobacco directly affects whether teenagers smoke, so that you can get a measurable percentage reduction in teen smoking with a 10% increase in the price of tobacco. And again, there are estimates for smoking bans and their ultimate savings in terms of cost societally. The other good thing about the tobacco example is we truly have evidence that we've turned the curve, so to speak, that the consumption of tobacco in this country by adults has gone down. And I think the lessons to be learned from this experience is, first of all, that it took us a good 50 years to have this effect. So someone earlier mentioned that you have to be in this for the long term. It's not a short-term benefit. And that we've used multiple different approaches all together and synergistically to have this effect on tobacco consumption and exposure of children to tobacco. So let me go on to the second case, obesity. Now, this is clearly an emerging health problem. I'll show you some figures in a minute that dramatically demonstrate it. But the patterns of obesity clearly begin in childhood. The data from last year is that 17 to 18% of children are now overweight, meaning they're greater than 90th percentile in weight for height. And clearly the implications of obesity in childhood are lifelong, with increasing levels of cardiovascular disease, type 2 diabetes, complications in pregnancy. Here are these dramatic maps that come from the CDC, from the Behavior Risk Surveillance System. As the maps go from white and light blue to dark blue to orange to red, what you're seeing is an increase in the prevalence of obesity in this country from levels of less than 10%, which is what you'd expect for the 90th percentile, to states which now have greater than 30% of all adults weighing more than the 90th percentile. A dramatic change across the U.S. The data are good that there's a cost to this epidemic of obesity. The estimates are that overweight children now spend about $109 billion in direct costs and $75 billion in indirect costs, again adjusted to $206. A lot of this cost is borne by Medicaid and Medicare later on. It's an increased level of hospitalization among obese children, but often we can't ascertain all of the indirect costs. There have been specific studies that have looked at the cost per child of obesity. So these are studies which use data from primary care centers that look at overweight children and obese children and the increased amount they spend on their direct health care during a year. For every 1,000 children aged 5 to 18, the excess spending is $25,688 per year due to unhealthy weight. So again, we're beginning to generate data on the cost of obesity. There aren't as many studies that show we can do something about this problem. So in searching the literature, we have identified some programs in the preschool period and related to parents' education and teachers' curriculums which seem to be effective in reducing the level of obesity in childhood. We don't know as much about the long-term implications, whether these programs implemented early will have long-term effects. They all seem to work by a combination of improved diet, increased exercise. They have multiple modalities. They're not single programs that have a single effect. The last example I want to bring to your attention is injury. Injury is one of those public health problems that's often overlooked. The magnitude of the problem, however, is enormous. We're talking about over 15,000 injury deaths a year in the United States. It's clearly the leading cause of childhood death. It's the leading cause of childhood hospitalization. It's the leading cause of emergency room visits. It's the leading cause of permanent disability among children. Permanent disability meaning they carry it through their lifetime. I suspect in all of your businesses, a significant amount of the healthcare dollars that you're spending on premiums and health insurance is going to pay for children's injuries. The cost of children's injuries have been estimated to be about $21 billion in lifetime medical costs, and then a significant amount, nearly $100 billion in work loss over the lifetime. The good news is that we've done a great job of decreasing children's injuries, so that there's been a 52% decrease between 1979 and 1998. We've seen particularly a decrease in deaths from injuries, but that may partly be due to better medical care so that children continue to be injured but survive those injuries. And again, this is an area where, although all the costs accrue to the medical care system, most of the interventions are out in the environment, in the home, through improvements in environmental engineering, in emergency medical systems, and so forth. So those are the three examples that I wanted to bring to your attention. I think that in closing, the message that we would bring to conclude this is that we need to bring the discussion of of investment into the area of children's health. It doesn't diminish the focus on medical needs, on the need for full coverage for health insurance. It doesn't diminish the focus on improving early childhood education. The two are complementary. We know that there are investments in preventive child health that have potential for cost savings. I think we need to do more work on documenting those potential savings. In other studies that are going to be looking at health consequences, we need to bring the adult costs back into the equation about children. We don't think about savings that might take place 60 years out as being a factor in whether we would invest in early childhood health, but we need to start doing that. We need to develop a methodology for doing that. We also need to think about ways of thinking about funding across different domains and different systems. So the one example that I wanted to bring to your attention is that there's currently a bill in the Maryland legislature to increase the amount of physical education in schools. And ironically, that bill is being opposed by the teachers and the education system because it increases their costs. So that what we're doing is we're pitting children's need for education against their ultimate health care needs, and we need a way of bringing those together in such a way that we don't create those kinds of conflicts. So I guess I would finish by just saying I think we should imagine a world where all kids are healthier and able to learn and able to get adequate exercise, not be exposed to tobacco, and live in safe environments. Thank you.